Good morning, family, and welcome to the opening keynote with Dr. David Williams. I would like to start with gratitude by honoring the land we inhabit and represent for all those who have come before us, the organizers of this event, and the opportunity we have to connect with one another. The first night of the MFP Summer Institute ended on an inspiring, motivating, and encouraging point. As we enter into the second day of the program, we have a remarkable speaker who has schooled scholars from all over the world who will join us today and continue the momentum by being a beacon of conducting excellent and impactful research and being a bold truth teller. Today, I have the extraordinary and slightly intimidating pleasure of introducing Dr. David Williams. Dr. Williams is the Florence Sprague Norman and Laura Smart Norman Professor of Public Health and Chair of Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. If that is not impressive enough, his TED Talk titled How Racism is Making Us Sick has challenged the prevailing yet shallow research on racism by boldly stating that is not good enough. He was also a key scientific advisor to the award-winning PBS film series Unnatural Causes: Is Inequality Making Us Sick? He was elected to the National Academy of Medicine, formerly the Institute of Medicine in 2001, the American Academy of Arts and Sciences in 2007, and to the National Academy of Sciences in 2019. He has also received distinguished contribution awards from the American Sociological Association, the American Psychological Association, and the New York Academy of Medicine. He was ranked as one of the top 10 most cited social scientists in the world in 2005. And when I Googled scholar him, I found out that I have definitely used some of his papers in my own research. And he's the most cited Black scholar in the social sciences in 2008. In 2014, Thomas Reuters ranked him as one of the world's most influential scientific minds. It goes without saying, but I must say it anyways. This is an abbreviated synopsis of the width and the depth of his contributions to the science and society at large. In this deep spirit of gratitude, Dr. Williams, I warmly welcome you.
Thank you so very much, Brianna, for your kind words of introduction, and thank you all for making time uh, to participate in this special program today. It's truly an honor for me to be with you. Not that long ago, actually, decades ago, I sat where you sit. I was a MFP fellow many years ago at the University of Michigan. And so I value the program. I'm familiar with it. And I say congratulations to all of you. And I wish you well in all of your endeavors. I want to talk today, and I'm going to share my screen so that you can see my slides about what I'm calling of the pernicious physical and mental health consequences of racism and its associated stressors. So I'm talking about the challenge, but I also want to talk about what we can do about it. I have a lot of territory to cover and I want to leave time for questions. So I'm going to jump right into my talk. I'm going to begin with what has captured the minds of Americans, what we talk about today, the COVID-19 pandemic that has so dramatically transformed our lives. One of the things we see in the pandemic is that deaths from the pandemic, varies markedly by race. So what this slide shows is not all deaths, because this is deaths through March 2, 2021, 520,000. We're almost at 700,000 deaths now. And it shows the age-adjusted odds ratios. So we are comparing the rate of death for the white population to other groups. And you can see the indigenous or Native American population have a death rate that is 3.3 times higher than that of the white population. Latinos, 2.4 times higher. African Americans, twice as high. Pacific Islanders, 2.6 times higher. Asians have a death rate that is similar to that of the white population. So what we are seeing is that the COVID-19 pandemic and deaths from COVID-19 were disproportionately on populations of color. Now, sometimes I run into people who think that because the death rate was higher for populations of color, that more people of color died. No, the rate and the number of people who die are two different things. So here, because the population of whites is larger, the rate is lower. But if you look at deaths through March 2, almost 300,000 of all the persons who died were white. And in fact, more whites died than all the other groups combined. You can see, for example, 73,000 African Americans died and almost 90,000 Latinos died. So I think it's important to keep those two things in mind. These are problems that affect all of us, but it has a disproportionate negative impact on populations of color. And so the question we are left with is, what drives these racial inequities in health? And keep in mind, in the interest of time, I'm not going to show you the data, but what is true for COVID 19 is true for most of the major causes of death in the United States. If I look at death
What am I
rates from
doing?
heart disease, from cancer, from stroke, from hypertension, from diabetes, in all of these things, I would see markedly elevated rates for populations of color. So, why does this exist? The first thing I would say is there are large racial ethnic differences in socioeconomic status. When I use the term socioeconomic status, I'm talking about things like income, education, occupational status, and wealth. And so to illustrate that, I'm going to use income data. And this is income data from the US Census Bureau for the year 2018. And I'm presenting it in a way that you can't miss the point. So I'm standardizing on the household income of whites of $1. And then I'm saying for every $1 of household income white households receive, Asian households receive $1.23. Two things to keep in mind to understand the Asian data. One, Asian households have more persons contributing to household income than any other group, because Asians are more likely than other groups to live in multi-generational live in households that are multi-generational. The second point about Asians, almost 70% of Asians in the United States are immigrants, and they've come to the United States with high levels of education. So taking those two things into account, the data is not that surprising. But let's look at the historically disadvantaged populations. For every dollar of household income white households receive, Latino households receive 73 cents, and Native American and African American households receive 59 cents. What is stunning about the 59 cents figure for African Americans is that is identical to the black white gap in income in 1978. You heard me correct, I did not misspeak. In 1978, the peak year of the narrowing of the black white gap as a result of the civil rights policies of the 60s and 70s and the war on poverty and the anti poverty policies that ensued from that, the gap was narrowed to 59 cents to the dollar. And in 2018, the gap is still 59 cents to the dollar. Has it been stuck at 59 cents since 1978? No. It got worse throughout the decade of the 1980s. Reaganomics was not good to the black population, and it wasn't until the mid 1990s that it got back up to 59 cents, and it's been a penny up and down since then. Important take home point. Most Americans, most of my students think we have made much more progress in the United States than that. And what these data tells us is there are large racial gaps in income in America, and they haven't changed much since the 1970s. And as bad as the income data are, they understate racial ethnic differences in economic status. What do I mean by that? Income tells us about the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income, like your savings and your checking and your investments and home equity and all the financial assets that you have. The latest data from the Federal Reserve Board shows that for every dollar of wealth that white households have, black households have 10 pennies and Latino households have 12 pennies. And when you are low income and you are low in wealth, in fact, for a lot of African Americans and Latinos, they have no wealth. What that means is even though we are all, as a nation, in the same storm of this pandemic, we are in different boats. Because when you don't have wealth, you are one paycheck away from being homeless. You can be one paycheck away from being able to feed your family, and you are in a boat that is less prepared to weather the storm. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in socioeconomic status. So, for example, if we looked at blacks and whites at the same level of income and education, race would no longer matter. We now know life is more complicated, and I'm going to illustrate that for you with national data for the United States life expectancy at age 25. So at age 25, how long will the average white person live compared to the average black person? There's a 5 year racial gap. The average white person will live 5 years longer than the average African American. However, if we look within the white population by income or education, I'm showing you the education data today, but the income data tells the same story. Whites who have a college degree or more education live 6.4 years longer than whites who have not finished high school. That is bigger than the black white gap. And the gap within African Americans, those with a college degree compared to those who've not finished high school, is 5.3 years. Importantly, the gap by education is also true for income within each race is bigger than the racial gap. So should we only look at socioeconomic status and not look at race? No, we need to look at both. Why? Because at every level of income and education, and here's the education data, race still matters. So white high school dropouts live 3.1 years longer than black high school dropouts, and that gap widens as education increases. And here is a stunning statistic, and remember, this is national data for the United States. The best off African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, than whites with some college, than whites who are high school graduates. So what does this data tell us? They tell us that there is something profoundly about income and education that matters for your health regardless of your race. But they also tell us that there's something else about race that matters even after you've taken income and education into account. And so researchers have been asking for the last 25, 30 years very intensively, could racism be a critical missing piece of the puzzle? Does racism contribute to these racial gaps in health? So I want to talk to you briefly about the house that racism builds. And I want to think of racism as a societal system, just like other powerful institutions in our society, like our political system, the legal system, the economic system, religious institutions, cultural institutions, and so forth. So racism, I see it not primarily in the beliefs and behavior of individuals, but as an organized system. Yes, it devalues and disempowers some. It differentially allocates opportunities and resources to groups regarded as superior compared to those that are inferior. And the system and the beliefs and the ideology that it fosters can lead to the development of negative attitudes and beliefs, prejudice, and stereotypes, and to differential treatment, discrimination by both individuals and societal institutions. But racism is primarily a system, and to fully understand it, you need to understand its systemic effects. And so I want to talk about some of the impacts of racism as a societal system. And I'm going to talk first about institutional or structural racism. I'm using those terms interchangeably. And we need to distinguish those from individual discrimination. A mechanism of institutional or structural racism that I have studied is called residential segregation. It's policies of the late 19th and early 20th century that determined where people could live in this country based on your race. This is a book written by a historian at Duke University. It's about the origins of segregation in the United States and in South Africa. He showed that the framers of apartheid in South Africa in the early 20th century looked across the Atlantic, saw apartheid, saw segregation working in the United States, and said, that is brilliant. We can implement that into our country and tweak it. Importantly, Sell argues that segregation was one of the most successful policies of the 20th century in the United States. And I will show you why, drawing on existing scientific research. But first of all, why would he say that about segregation? What does segregation have to do with anything? Well, think of segregation like a burglar that enters a community at midnight. Once it shows up, valuables disappear, like quality schools and safe playgrounds and good jobs and a healthy environment and safe housing and good transportation and even access to healthcare. All of those factors, research shows, are linked in these United States to the neighborhood in which you live. You want some evidence? Let me share with you findings from 3 studies that will show you how powerful segregation is in the United States. First, a study done by Robert Sampson and William Julius Wilson, two of America's most distinguished sociologists. This studied the 171 largest cities in the US. And they said because of segregation, there's not even one city where whites live in equal conditions to those of blacks. And it had this stunning statement: the worst urban context in which whites reside is considerably better than the average context of black communities. Now, if you paid attention, that's a 1995 study, and you say, well, Professor Williams, have things changed? Are things a lot better now? So here is a paper from Professor Dolores Acevedo Garcia, professor at Brandeis University. And what she did, she's ranked every county in the United States by what she calls a neighborhood opportunity index that captures almost 29 different indicators of access to opportunity for children. Things like the quality of elementary schools and early childhood centers, the high school graduation rate, the employment rate, home ownership rate, median household income, the quality of the environment in terms of air, water, soil pollution, proximity to hazardous waste sites, and resources for good health like access to green space and healthy food outlets and safe places to walk. But these are just some examples of the 29 different indicators. And what did she find? This is a 2020 paper, that in the 100 largest metropolitan areas in the United States, if we ask the question, who lives in those neighborhoods that are very low and low in opportunity, 2/3 of all African American children are in those neighborhoods. 58% of all Latino kids and 53% of all Native American kids, compared to 1 in 5 white and Asian kids. And if we go to the opposite end of the spectrum and we say, well, who lives in high and very high opportunity neighborhoods, almost 2/3 of white and Asian kids, and only 1 in 5 African American and Latino kids. So access to opportunity at the neighborhood level varies dramatically by race and ethnicity in the United States. In fact, the research shows the reason why there are differences in income and education is linked to opportunity at the neighborhood level. Here is a study by a premier economist in the United States, David Cutler. He's also a professor at Harvard. This was a national study he did where he looked at national data for blacks and whites, young cohort making it in the labor force. He showed statistically, if you could eliminate residential segregation in America, you would completely erase black-white differences in income, in education, in unemployment, and reduce racial differences in single motherhood by 2/3. So all of those striking differences are linked to what? Opportunity at the neighborhood level. One last study, Raj Chetty, another Harvard economist, but he asked a different question. He asked an intergenerational question. He said, let me use census data for all people in America, 1989 to 2015, got special permission to analyze his data. And his question was, let me look at black children and white children who start out life in America in households with the same level of income. How are the children doing in the next generation? And he found that for black boys, in 99% of census tracts, that's almost everywhere in America, black boys who start out in a household with the same level of income as white boys are earning less in the next generation. Why? They live in neighborhoods that differ in access to opportunity. If they live in neighborhoods with good resources, they do just as well. But those neighborhoods are few and far between in the United States. So I'm talking about structural racism in the US, and I'm talking about residential segregation that policymakers and politicians are not talking about. But what I'm showing you this morning is that the racial inequities in income and education that we're also familiar with do not reflect a broken system. Instead, they reflect a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. These inequities are not accidents, they're not acts of God. They show the way in which policies, upstream policies, have produced a truly rigged system in these United States. And that segregation, when you live, when you are first poor in economic status and live in disadvantaged segregated neighborhoods, you also have higher levels of exposure and greater clustering of a broad range of stressors: economic, psychosocial, physical, and chemical. So, all I have talked about is the ways in which this one upstream mechanism, and it's not the only one, segregation, creates inequities in the United States and creates factors that adversely impact on health. Another mechanism of discrimination, racism, I want to talk about is individual discrimination. And what I'm saying is the experiences of discrimination produced by this system can be an added source of toxic stress. One of the things that I did in my career was to develop a number of measures to capture experiences of discrimination. The most famous one is called the Everyday Discrimination Scale. Today is the most widely used scale to measure discrimination globally. And it doesn't capture the big things. There's another scale that captures the big things. These are just little indignities. You're treated with less courtesy and respect than others. You receive poorer service than others at restaurants or stores. People act as if they think you are not smart. They're afraid of you. They think you are dishonest. They're better than you are. A bunch of little indignities. What has the research found? There are not more than 400 published papers globally looking at the effects of everyday discrimination on health. And this slide will just summarize some of the findings. There are studies that find that people who score high on everyday discrimination have incident. That means the new cases. They're more likely to develop metabolic syndrome, cardiovascular disease, breast cancer, type 2 diabetes, more likely to engage in high-risk behaviors to cope with the stress of discrimination, more likely to develop multiple indicators of subclinical heart disease like coronary artery calcification, intima media thickness, heart rate variation, visceral fat, AFib, more likely to develop high blood pressure, more likely to have poorer sleep quality, poorer sleep duration, more likely to have multiple indicators of biological dysregulation like elevated levels of inflammation, of cortisol, lower telomere length, higher allostatic load, more likely to be obese, less likely to engage with the healthcare provider, and higher rates of mental disorders as well as of emotional distress and lower psychological well-being. So just this slide shows you the devastating impact of the stress, the little indignities of discrimination on health. Professor Chester Pierce here was a Harvard psychiatrist, and back in 1970, he wrote a paper about the topic of what he called microaggressions. And he called them assaults to Black dignity and Black hope. And he said they are incessant and cumulative. And what the Everyday Discrimination Scale is doing is showing that what Professor Chester Pierce said was correct. These offenses, these microaggressions, have profound negative effects on health. And I just want to remind you that this everyday discrimination is on top of all of the other stresses they deal with. So I'm going to give you a study that I did with other colleagues looking at probability data for the entire city of Chicago. And in Chicago, Black and US born Latinos have higher levels of major life events like the death of a loved one. They have higher levels of financial stress like difficulty meeting monthly payments on their bills. They have higher levels of relationship stress like children or friends making too many demands on them. They have higher levels of neighborhood stress, like having vacant and deserted buildings, having their home broken into, being a victim of robbery, have higher levels of then discrimination on top of that, discrimination at work, major experiences of discrimination like being fired from a job or unfairly denied a promotion, and everyday discrimination, which we just talked about. And what's the consequences of all of that? This is what we found in that study. We counted the number of domains of stress that individuals were high on. and look at the findings for depressive symptoms. If you're high on one, as you go high on two, on three, on four, on five, the more domains of stress you're high on, the higher your levels of depressive symptoms. We also see that for poor self-rated health as well. So I'm showing you that all of these stressors have what we call a dose-response relationship between the number of stressors individuals are exposed to and their physical and mental health. And then what the research is also showing us is that there are hidden ways in which stressors linked to race and racism also adversely affect health. One example, this is an early study done with Professor Brandisha Tynes. She's now at USC. She was a postdoc with me when she did that many years ago. Was the first study of online discrimination in the United States. What we did in this study was looked at middle school and high school students, and we measured the discrimination they experience in online contexts. And what we found, that even after we took into account discrimination they had offline and a global measure of stressors that adolescents face, we found that online discrimination was positively related to higher levels of depressive symptoms and higher levels of anxiety symptoms. So online discrimination was making a unique, distinctive contribution to the mental health of these teenagers. More recently, Professor Tynes has published a study back in 2019 looking at the experiences of Black and Latinx adolescents, 11 to 19 years old, looking at how often they have seen online an image or video of someone of their own racial ethnic group being beaten, being arrested, being shot by the police. And what she finds, the higher levels of exposure to online traumas online in the prior year is linked to higher PTSD and depressive symptoms. This is a study I did with one of my former students. We took a database over 3 years of every police shooting in the United States. And we linked that to another database from CDC with the mental health of the population in every state. And what we were able to show is that every police killing of an unarmed Black person led to declines in the mental health, not of just their family and friends, but for the entire Black population in the state in which that occurred for the next 3 months. So what this is showing is that these experiences have a cumulative impact because they make all of us feel we are vulnerable. Importantly, we found this effect was true only for police shootings of unarmed Blacks. If the Black person was armed and shot by the police, there was no effect on mental health. But it was the police shooting of an unarmed Black person suggesting to us that it was the perception of unfairness and therefore also the perception of your own vulnerability. Because if you could be doing nothing wrong, being unarmed, and still be killed by the police, it could happen to any of us. Or in my case, the father of 3 daughters, my daughters worry about me and my well-being when I leave the house. Another way in which all of these stressors have consequences that we sometimes don't even think about is what Professor Umberson from the University of Texas calls community bereavement. I showed you the data on COVID-19 deaths, that Blacks have more deaths, right, from COVID-19. But then if you are in a community, it means that more of your friends and relatives are dying, and they're dying at earlier ages. In fact, looking at national data, she documents that Black children are 3 times as likely compared to white children to lose a mother by age 10. Black adults are twice as likely to lose a child by age 30 and a spouse by age 60. And this loss of social ties, we'll talk about how important they are in a minute, earlier in life and more frequent, absolutely has a negative effect on health over the life course. And then there's the racism in the larger environment that can also have health consequences. This is a study that asked a sample of Black women how concerned are they about what might happen to their children? And over 70% of African American mothers said that they were very concerned that their children might be harmed by the police or their children might get stopped in a predominantly white neighborhood. And we have not fully assessed the impact of this stress on these moms. Here is a study that shows that the higher levels of racial prejudice in the community, it's a study of 1,800 counties in America, and the researchers had data from a large database on the levels of prejudice on average from people who live in those counties that had filled out a questionnaire on a website with millions and millions of people. And what it found is that in counties where there was more people express prejudice against blacks, in those counties, the death rate for heart disease was higher for both blacks and whites who lived in that county, with the effect stronger for blacks. In fact, 11 more blacks died annually in counties where the levels of racial discrimination or racial prejudice were higher. Now, we don't exactly know what the mechanisms are that leads to more prejudiced people in the neighborhood and to higher rates of death, but it's something we need to better understand. Another example, and this is a study I did with colleagues using data from the Kaiser Permanente system in Southern California of 5 million lives. We looked at the impact of the 2016 presidential election on health. And the health outcomes we looked at is being hospitalized for heart attacks or stroke. And we found that 2 days after the election results, presidential election results, the election of Donald Trump in 2016, the 2 days after, there was a 1.6 times increase in hospitalization in Southern California for heart attacks and strokes compared to the 2 days before. It suggests to us that even this environment of politically polarized environment in which we live, that stress linked to political campaigns, to political rhetoric, and to election outcomes can even be a source of stress on the health of individuals. One last study about the potential impacts of presidential elections. This is a study published in the JAMA Network Open, national birth data on Latinos in the United States, studied Latinx women and looked at preterm birth rates before and after the 2016 presidential election, and found there was an additional 2,337 preterm births born to Latinas in the 9 months after the 2016 election compared to the rate before the election. This pattern was pronounced in certain stages of pregnancy, most pronounced for infants conceived or in the second trimester around the time of the election. And this has a huge cost. $182 million is the estimate of the additional expense of these 2,337 babies born preterm just in the first year of life. So it's costly to all of us. So I've talked about racism and its effects, the institutional structural racism, the individual discrimination, and the other ways in which racism plays out to affect health. And there's also racism. I'm not going to spend a lot of time on this in interest of time. There's the racism that's deeply embedded in our culture that plays out in stereotypes and stigma and assumptions we make about people just based on their race. The research finds that negative stereotypes about race, they are deeply embedded in our culture. Most Americans have high anti-Black bias. And when I say most, the research shows that every group in America that has been studied, every racial ethnic group, every occupational group, doctors, lawyers, teachers, police, it doesn't matter which group you look at least 70% have an anti-Black implicit bias. 70%. The only group that is the exception to that is blacks. And even among blacks, 1 in 3 black people have an anti-Black implicit bias, because it's not about what your skin color is. It's about what's embedded in your mind. I like to tell my students that I think of myself as a prejudiced person. And I tell them I think of myself as a prejudiced person because I would like to think of myself as a normal human being. And I want to give you the news this morning. If you're a normal human being, you're probably prejudiced. Now, I didn't say you're racially prejudiced because this is not about race. This is about how all of us process all of the complex cognitive information that we face every day. We process that information by putting things into categories. We call that social categorization. And when you meet someone from a category for which you have negative beliefs and expectations, and every culture, every community has in groups and out groups. Groups that are viewed positively, groups that are viewed negatively. And when you meet someone from a group that you have negative stereotypes and assumptions and beliefs about, you will treat that person differently. That is, you will discriminate against them. It's an automatic process, it's an unconscious process. And you may not be racially prejudiced, but I would ask you, what may be your stereotypes about other groups, about poor people, or fat people, or gay people, or women, or old people? You get the point. This is the process of group categorization that we all use, and we treat persons differently based on the negative assumptions and stereotypes we have in our subconscious based on where we were socialized. And research documents that this implicit bias leads to differences in quality in medical care. I want to share with you work done by, this is Professor Lisa Cooper from Johns Hopkins University. She studied safety net providers in safety net clinics in the greater Baltimore area. She assessed their implicit bias, and she found that those providers high on implicit bias, even though they cared enough that they were working with the most vulnerable, the quality of the interaction on multiple dimensions, based both on patients' reports about the last encounter as well as videotapes of the encounter, and had objective raters rate the quality of that encounter, they were rated more poorly. So that the implicit bias affects not only the care we provide, but the way we treat others and the quality of the patient-provider relationship. I want to tell you there's good news. This is a study from colleagues at University of California, San Francisco. They found, studying persons with HIV/AIDS and looking at whether they got antiretroviral therapy, did the therapy work, did they follow through and take the therapy as they were supposed to, and what they found, that in general, there were large racial disparities in receiving antiretroviral therapy, in the patient following through and taking the therapy as they were supposed to, and in the therapy actually working as it was supposed to. However, they found that regardless of the race of the provider, no disparities were evident when cultural competence was high in the provider. Now, what was cultural competence? They measured it with a 20-item scale. I'm going to show you 6 items from the scale so you get a feel for the kind of person and the kind of provider where there were no racial ethnic disparities in the quality of care and the following through on the impact of care and the care working. There was providers who agreed that family and friends are as important as health as doctors, that social history contributes to how they care for their patients, that they were familiar with the lay beliefs their patients have, that they asked their patients about alternative therapies they use, and they found out what their patients thought was the cause of their illness. What does that give you? It doesn't tell us how we get there, but it does give us a model of a set of providers who engage with their patients, who respect their patients, who talk to their patients, who try to understand where they're coming from, and then provide the best care they have. And among those providers, no disparities existed, or they involved their patients in decisions about their health care. I didn't miss that one as well. Okay, I've talked about the problem. Are there factors that make a difference in reducing the negative effects of all of these stressors on health? Yes. The first factor I want to talk about is the quality of social relationship, the quality of social ties. And to illustrate the power of social ties, I want to tell you about a study that Jane Brody did in the state of Georgia. He'd been following black adolescents in rural counties in Georgia. He measured discrimination on these kids at age 16, 17, and 18. And he found that those African American teens who were stably high on discrimination at 16, 17, and 18, 3 time points, they had higher levels of biological dysregulation by age 20. I didn't say age 40, I didn't say age 30. High on discrimination as a teen by age 20, higher levels of the stress hormones, cortisol, epinephrine, norepinephrine, higher levels of systolic and diastolic blood pressure and inflammation, and higher BMI. However, the relationship between discrimination and biological dysregulation is broken among those African American teens who were high on social support from their parents, their teachers, their friends. In other words, the quality of social ties erase the negative effects of discrimination on their biological functioning. So social ties are really powerful. Here is another study that shows that social ties, specifically within the religious context and religious engagement, can also be a protective resource. A national study of African Americans found that multiple aspects of religious engagement, frequency of religious attendance, receiving support from the members of your congregation or place of worship, and seeking religious guidance in your everyday life, these religious factors reduce the negative effects of experiences of discrimination on mental health. So here is another resource for religious individuals. Religious engagement can be a protective mechanism. A third one, and now I'm going to a study in Canada, looking at First Nations, the indigenous people of Canada. This, as a group, the teens, First Nation teens, had one of the highest rates of youth suicide in the world. And in this study, researchers looked at the period 1987-1992. Here is a population with one of the highest rates of suicide. They studied 196 First Nation communities and found that about half of the communities had no youth suicides at all. So even as a group, with very high rates, there's some places where there are no suicides at all. And so the researchers identified 5 markers in those communities of challenging the federal government of Canada for titles to land, for the right to self-governance, for control over services like education, healthcare, police, and fire, and having a building for cultural activities, so they celebrated their culture. What they found was that each of those indicators of advocacy, protest, empowerment, and cultural affirmation was associated with a lower risk of youth suicide. In other words, when those young people had something to fight for and something to live for, it lowered their chances of committing suicide. This study found a strong dose-response relationship between the number of markers of advocacy, protest, empowerment. So it means, yes, Black Lives Matter and engagement with Black Lives Matter could actually be good for the health of young people in America and be an aspect of promoting better mental health. At the same time, I want to tell you that there is a paradox of Black mental health in the research data. And what do I mean by that? I've shown you the higher levels of stress. I'm showing you the levels of stress are linked to higher rates of mental health problems. So you would predict that Black people would have higher levels of psychiatric disorders than whites. In fact, the best data that we have show that the opposite is true. So here is the best evidence we have in the United States from the National Comorbidity Study, the National Study of American Life, the National Study of Latinos and Asian Americans. And here is the lifetime prevalence of psychiatric disorders. And you could see for whites, it's 37% of the population have meet criteria for DSM-5 defined psychiatric disorder at some point in their lifetime. For African Americans, 30%. For Caribbean blacks, 27%. It's pretty high for Puerto Ricans. It's the Puerto Ricans in the US, 39%, much higher than for other Latinos. And you can see the levels for different Asian groups. If we look at the 12-month prevalence, you see the same thing. Whites are much higher than African Americans. Now we see Caribbean blacks slightly higher than African Americans. Again, elevated rates for Puerto Ricans in the US, other Latino groups, Asian groups. So it's interesting. We would expect that African Americans would have higher rates of the common mental disorders. They don't. In fact, I want to show you, this is a study we published from this same data years ago, looking at the level of major depression among blacks. This is national data for the United States. This is persons in treatment and not in treatment, so it's comprehensive. And what we found, that blacks have lower current rates and lower lifetime rates of major depression than whites. However, once blacks are depressed, they were more likely than whites to be chronically or persistently depressed. So they do better in terms of protection. Once they get it, it's more chronic or persistent. They have higher levels of impairment, so a greater negative impact on their ability to function. They have more severe symptoms, and they are less likely to receive treatment. How much likely were they to receive treatment? This is from that same study. This is the percent of American adults who met criteria for major depression in the past year that received some kind of therapy. Okay, all of these people have met criteria for major depression in the last year. Did they get any kind of therapy in the last year? 57% of all US adults get therapy, got some therapy. But only 45% of African Americans. Among Caribbean blacks, it's even worse. Only 24% of Caribbean blacks with meeting criteria for major depression got treatment. So there's a huge gap that needs to be addressed within the black community in ensuring greater accessing of treatment among persons. There's also some ominous storm clouds. This is data of national study of elementary school children in the United States between 1993 to 2012. And what it found, that over this period of time, there was a large increase in suicide for black children. In fact, suicide declined for black children, but doubled, declined for white children, but doubled for black children. And remember, this is black children age 5 to 11. These are elementary school children, and you could see if we just look at boys, what happened 1993 to 2008 to 2012. You can see the doubling of suicide for black boys compared to the decline for white boys. More recent data shows even through 2015, they see the same thing. It's occurring, and it's not just on kids 5 to 11, it's on kids 5 to 17. It's even a larger age group. And we are seeing this dramatic increase in suicide is something we need to be concerned about. Let me wrap up by talking about what else we need to do. All the things I have talked about, the resources that communities use, social ties, religious involvement, protests, and empowerment, those are good things to do. But long term, we need to create what I call communities of opportunity to minimize, neutralize, and dismantle the systems of racism. We need to enrich the quality of neighborhood environments. We need to enhance economic development in poor areas. We need to improve housing quality and the safety of neighborhoods. Those are key things to improving health. Here are a number of strategies. I don't have time to discuss them all that we need to put in place, and I'm going to give you examples of 2 of them: investing in early childhood and improving neighborhood and housing conditions. But we need to reduce child poverty. We need to enhance income opportunities. We need to enhance workforce development for youth and adults. We need to create more economic opportunity. Investing in early childhood. Here is a study from North Carolina, the Abecedarian Project. It took poor kids at birth, randomized them to receive a high quality preschool program, nurturing environment, good nutrition, good pediatric care, good intellectual stimulation. By age 20, those kids have fewer symptoms of depression, the intervention group compared to the controls, lower marijuana use, more active lifestyle, greater educational success, greater vocational success. By their mid 30s, they also have lower levels of risk factor for cardiovascular disease and metabolic disease. So, for example, here are the differences in systolic blood pressure in the treatment group, those that got the program, versus the control group who didn't get it. And it's not just blood pressure, but BMI is lower. They're doing a whole lot better. Let me give you an example of what we can do to improve neighborhood and housing conditions. Because a lot of people think it's too hard, there's nothing we can do about it, it's too complicated. Come with me to East Lake Meadows, an African American public housing project in 1995 in the city of Atlanta. It 90% of the residents of that facility were victims of a felony every year. It was public housing with many units unlivable. Only 13% of adults were gainfully employed. The elementary school was one of the worst performing in the state of Georgia. Come with me to the villages of East Lake. This place has been completely transformed. They have torn down the housing project. They have rebuilt with half the residents qualifying for public housing, half are at market rate, 90% reduction in violent crime, mixed income, high quality housing. All able-bodied persons are employed, and the school, although 60% of kids in the elementary school qualify for reduced price lunch, the school is one of the top performing in the state of Georgia. What does the purpose build show? That it can be done. Yes, we can address all the challenges faced by poor communities simultaneously. Yes, we can provide comprehensive, integrated, place-based solutions. Yes, we can develop a cradle-to-college pipeline of high-quality education, provide quality mixed-income housing, and a broad range of services. What we need is the will to do it. Shirley Franklin, former mayor of Atlanta, is the chair of the board of Purpose-Built Communities. This is the organization that did this in Atlanta. They are doing it in multiple communities across the United States, and they will provide free technical assistance to any community who wants to replicate their model. So I leave you today with the words of Martin Luther King. He said, "It may well be that we will have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and the indifference of the good people." What I've showed you today is that there are inequities on a large scale, creating poor mental health, creating premature death, that is hurting large segments of our population. Are we going to be silent? Are we going to be indifferent? Or are we going to work together to change these conditions, to advocate for change, and to create a better future and opportunity for every American child and every American adult? Thank you for your time and attention this morning. I look forward to the questions that you have for me to answer today.
No, thank you for your time today. I was wrapped with everything that you're saying, and I'm going to start with a question, and then I'm also going to open it up for the questions in the chat. So I'll give people some time to get their typing in. And I also really appreciate that you leave us on a quote with Dr. Martin Luther King as well. Whenever I see him, I think of my favorite quote by him is that we must not accept infinite disappointment, but never lose hope and never lose infinite hope. I'm not a great paraphraser. I'm just sort of like,
good.
let me Google it real
It's a
quick.
good message. We got it.
Yeah. So I have the first question, and I see some are starting to pop up in the chat as well. But since you had a hand in the Unnatural Causes documentary, based off what you've seen in the last 10 plus years since the film was released, what do you think are some of the main things that have stayed the same? And what do you think are some of the things that you have changed in that time?
It's a great question. I think Unnatural Causes had a huge impact. It's widely used as an educational tool in colleges and universities, undergraduate programs, medical schools, public health schools, all kinds of social science programs, nursing programs across the United States. So it has certainly gone a long way in raising awareness levels of the inequities that exist and what we can do about it. But I would honestly tell you that George Floyd's death had an even bigger impact in raising awareness levels that something is radically wrong in this country when someone could put his knee on the neck of another human being for over 9 minutes. And I think that too is really creating awareness and asking people, let us learn, let us understand, let's understand these hidden dimensions of racism that operate and are systematically producing inequities in the US.
That's wonderful. And then we also have just a quick reminder that the speakers and moderator bios are within the briefcase of that you could see at your convenience. And then we have Griselle who has a question who's up.
I wrote it down. My question, I'm sorry, I'll go back and, and read it. What words of wisdom do you have for faculty or nurses of color who serve as a voice for this type of information on structural racism, health inequalities, when it's a challenge to speak up and point out opportunities for improvement at work, when you're kind of the only one because others tend to step back because it's a safer area?
I am so glad you asked that question because there's something I should have mentioned and I didn't. I serve as the co-chair of the Future of Nursing 2020 to 2030 committee. That committee's report from the National Academy of Medicine, National Academy of Sciences was released in May of this year. It has been endorsed by every nursing organization, and the focus of the Future of Nursing report is how do we equip nurses to address the social determinants of health and reduce inequities. So there are recommendations in there, so you don't have to stand on your own. You can now cite what the National Academy of Sciences says and what all the nursing organizations have committed themselves to do, of what they will do to first ensure that nurses are allowed to practice at their full capacity of their training, that nurses, there is investment on the part of employers on nurses' well-being so that nurses are cared for so they can effectively care for others, that we radically transform the curriculum of nursing schools so that questions of racial disparities are not an adjunct lecture or course, but are integrated into the entire curriculum, that nursing leadership plays a larger role. So it's a wonderful report. You can find it online for free, download it. It's long, it's over 500 pages, but the Future of Nursing report, and there's activity at the level of every state with organizations embracing the report and holding nurses to account of what can be done to address these issues. But part of the issue, there are chapters on what nurses can do to address and improve health care equity in the United States, as well as health equity in the United States. So I'm really glad you asked that question.
Our next presenter, Dr. Hasmiller, actually is going to be talking about the
Okay, wonderful, wonderful. Yes, yes.
And our next question comes from Shai Wilson. What impact does whiteness of the DSM criterion affect African Americans' depression diagnosis? What are your thoughts on subclinical depression in African Americans?
Those are really good questions. In the study that we did, this was done in the National Study of American Life. It was a study. I was part of the team at the University of Michigan at the time, led by our great colleague who passed away a little more than a year ago, James Jackson. And one of the things we did in that study, and also in the National Comorbidity Study, which was a study run by Ron Kessler that was nationally of all racial ethnic groups, is that we did clinical validation in the study. So the diagnoses were obtained as a result of a questionnaire that was lay administered. So we didn't have clinicians doing it. And then we, in this questionnaire, operationalized DSM criteria. What we did was did a re-interview with a clinician with a random subset of the people who had taken the survey already and looked to see what is the concordance between the clinical diagnosis that came from this computer-generated algorithm based on the answers of the individuals that operationalized DSM versus what happens when a clinician interviews the respondent. The results, it wasn't perfect concordance. You never find perfect concordance because, for one thing, they were being introduced sometimes 3-4 weeks later than the initial interview. They weren't done exactly at the same time, but we found high concordance. There was actually of interest lower concordance for Caribbean blacks than there were for African Americans, suggesting whether there may be some cultural differences there. We're not certain of what they might be, but there was lower concordance for Caribbean blacks than for African Americans, but there was adequate, respectable concordance suggesting that the data that we have are pretty reliable. So what we find, and your question is there kind of depressive symptoms that's subclinical? There is evidence of that, because if you look at studies that use the CESD or the K10 or other measures of depressive symptoms, the studies are inconsistent, but several of them find African Americans have higher levels of depressive symptoms, but they have lower rates of clinical depression, suggesting that there may be an elevated risk of depressive symptoms that's subclinical and that is not really meeting all of the threshold criteria. But I think what I would say, as someone who has worked in the mental health field, looked at the literature on psychiatric disorders for African Americans, there may be more evidence of clinical misdiagnosis in the area of psychosis than in the area of depression. But I think that I'm not saying that the data are perfect and the data are without error, but I think the data are quite reliable. And one thing that gives me further confirmation that the major depression data are reliable, look at the suicide data. For 100 years, African Americans, despite their living conditions, despite the stress, despite the discrimination, African Americans have had markedly lower rates of suicide than whites. That's true nationally. That study that I showed you, showing the doubling of suicides among African American kids in elementary school, is the first study in decades that has shown a higher rate of suicides among African Americans compared to whites. And now there are a couple other studies that found similar patterns among young people. So we are seeing it. And by the way, I think that there's a huge take-home point there, because to me, the question it raises, what does it mean in this country with all the racism that is so virulent on social media and so virulent in many contexts and is so evident even among some of our political leaders? What does it mean to be growing up black in America? What does it mean for 5, 6, 7, 8, 9, 10-year-old? That's the group where we are seeing the most. It's up to age 13 that we're seeing these higher elevated rates of suicide. And it really should make us all stop and take a breath and really think of how do we build communities where we respect and acknowledge the dignity of every human being, and we transform the ways in which we relate with each other. But thank you for that question. It's a great one.
Okay, so I just wanted to make an announcement that your presentation will be available for a year after August 23rd. And also, since you're speaking to students and forever students, our favorite question is, will the slides be available?
I'd be happy to make the slides available to you. You can post them as a PDF.
Okay. And then the next question that we have comes from Marlene, asking about the rates of anxiety in the Black population.
What we find for major depression, we also find for anxiety disorders. There were, if somebody really knows the literature well, there was a study, the first kind of population-based studies done in the United States, done in the early 1980s, that were called the ECA studies, epidemiologic catchment area studies. And those studies found that African Americans had higher rates, not of anxiety in general, but particularly of the phobias. That has not been replicated in better data on more recent studies that had phobias measured better than they were measured in that study. So the general point is, what we find for African Americans, for the common mental disorders, anxiety disorders, mood disorders, substance abuse disorders, where the image and the perception is that African Americans are high on substance use. No, we find lower rates of all of these disorders for African Americans compared to whites. But then again, remember the flip side of that, it doesn't mean there are no disparities. What I showed you for depression is, although you're less likely to have it, once you get it, everything is worse. Greater impairment, greater severity, greater persistence, less likely to get treatment. So there are still important challenges that we face in the area of mental health.
Okay. And so we have a little bit less than 5 minutes, and I have a final question, but well, two questions. The first one is just the racial effects on gentrification on Black lower income families and seniors. Do we know of any studies or just kind of meta thoughts on the subject?
So I don't think we have good systematic data. There are some studies that have looked at that. So, for example, there was a classic study called the Monitoring, Move into Opportunity study that took African American residents of public housing in select cities in the United States. And randomly, it was a randomized control trial, took these African Americans, some were randomized to remain where they were in public housing, and some were randomized to move to areas of lower levels of poverty. And what we found, improved health, improved mental health, improved physical health. 10, 15 years later, lower rates of obesity, lower rates of diabetes risk in those who moved. So just by changing the neighborhood led to improvements in health. At the same time, the research also indicated that many of the persons, no, I shouldn't say many, but some, a non-trivial subset of persons who moved back. And one of the biggest reasons why persons move back is that although they were living in a different environment, their social network had been completely disrupted. And so the take home message that I have from that is you shouldn't have to move from your neighborhood to live in a better neighborhood. We need a Marshall Plan for disadvantaged communities, a Marshall Plan that we invested in to rebuild Europe after the Second World War. We need a Marshall Plan for disadvantaged communities in the United States, where we will invest and improve the access to opportunity at the neighborhood level in disadvantaged communities so that people have access to jobs, have access to opportunity. The purpose-built model shows you create the opportunity, people want them, they benefit from it, and we see the results. So I think, yes, we need to think of what we can do to improve neighborhood conditions in the places where people live.
Okay. So I don't see any additional questions from the chat, but I do have one for you. So what's bringing you joy in this coronavirus season, and how do you care for yourself? And especially when you're doing lots of research where we're not getting great statistics and wonderful things about just our communities. So how do you care for yourself, and what brings you joy during Corona season?
Thank you. That's a great question. I would tell you that my biggest source of pride and joy in my life, in addition to my grandchildren but, and my family, but the biggest source of pride and joy, honestly, is the success and the work that my students are doing, and students and fellows that I have worked with. It gives me hope for the next generation. It gives me hope for the future to see back in the early days when I started doing work on racial discrimination and racism in the early 1990s. I could count on one hand the researchers in the world who were doing work on racism. And I can't even keep up with the publications on racism today. The field has been completely transformed, and there's so much work and so much important work going forward. And I am so proud of so many of my students, the commitment they have, students of all racial backgrounds, the commitment they have to a vision of a new society where there'll be a greater sense of brotherhood and a greater sense of a commitment to equity. That gives me hope. In terms of what I do, yes, I have been working remotely since March of last year. Have been into my office once for 2 hours. I was allowed back into my office, and even then I was limited to 2 hours in my office. We are going back in person the first week of September. Everyone has to be vaccinated, and even if you are vaccinated, you have to get a COVID test once a week.
Mhm.
So we are very serious, and that's true when I say everyone, every faculty, every staff, every student at Harvard has to be vaccinated. So we are going back, but everyone will wear a mask indoors. There is a sense in which we will have a greater sense of community than we have had in the last year and a half, and we are looking forward to that. But what has kept me going certainly is family and friends. I think I have reached out more to family and friends during these times. I have remained active in terms of physically taking care of yourself, getting your sleep, just the normal self-care things. But also, I have had the opportunity to use my voice to speak about these problems of inequities more in the last 18 months than I have done in my entire career. I've spoken to more corporate boards in the last 12 months that I've done in my entire career before that. So I am inspired and encouraged by the greater interest of every sector of American society in terms of trying to understand racism and trying to work towards doing it. What I would say to all of us, we can't sit on our laurels. We can't fumble the ball, to use a football analogy. We have to take advantage of this opportunity. This crisis is going to be a terrible thing to waste. So let's take advantage of this opportunity and keep the feet to the fire so that we can really have a better generation for my grandchildren, is the way to think of it.
Thank you so much, and a wonderful way to end this session. Thank you again.
Thank you all. And good